I don't. But that doesn't mean something can't happen to me before you. And I think if we put that, into effect with our patients, sometimes I think it helps them to, okay, we're not in a bubble. So our case study is a typical lady you would see in your nursing home. She's 84 years old. She has COPD. She has a history of UTIs with sepsis, and she has some dementia. We've seen that slowly but surely she keeps declining. She's not doing as much for herself as she was, which is something that we actually expect. I happened to be in the facility on a Saturday. It was my weekend on call. Nurse comes running down the hallway. This lady has spiked a fever. She's not eating. She used to have real good appetite. She just didn't want anything to eat. She's real lethargic. She wants to sleep. She doesn't want to wake up much. She's refusing to get out of bed altogether. And she had been getting up every day sitting in her chair. He took her O2 sats, and they were down in the 80s, but she had her oxygen on. Wasn't like she'd taken it off. She didn't look like she was struggling, but still those O2 sats were really low, and we took them with more than one machine to make sure that that was right, that we didn't have a faulty machine. And she kept saying she didn't have any pain. She said, no, I'm fine. But we knew something was wrong. So I want you to keep that in your mind as we talk, and then at the very end we're going to go back to this lady, and then we'll discuss her a little further. So optimistic is the nice little easy way to say optimizing patient transfers, impacting medical quality, and improving symptoms, transforming institutional care. So our wonderful Dr. Kathleen Unroe came up with this. And I said, well, I'm sure glad it worked out to be a good acronym, because I'd hate to try to spit that out all the time, because that's just too hard. So again, it's to reduce those avoidable hospitalizations, because we know there's going to be times we can't avoid a hospitalization. We have to send them out. And it's not that we don't want to send them out, and it's not that CMS doesn't want them to go. We just don't. We don't like that revolving door of, I'm bored and I need something different to look at, so send me to the hospital. Trust me, I've got patients like that. Again, the different 7 projects nationally: New York, Pennsylvania, Alabama, Missouri, Nevada. I think Alabama's the one that's looking more at diabetes as their issue, as to how do I intervene on diabetes. So like I said, each project has a different view of how to get to the same end point. So, like I said earlier, we have 19 facilities, and what we look at are those long-term stay residents, those people who've been there at least 100 days or longer in long-term care. They don't have to have been in that facility. They can transfer from another facility. As we know, sometimes residents transfer facilities. If it adds up to 100 days, that's fine. If they come in and they have absolutely no plans for discharge, you know they're going to be there, then we see them too. So that does exclude anybody in rehab, because those people are still expecting to go home. Very few. The only other people that we don't see are those who are in managed care. If they're dual eligible, Medicare, Medicaids, those are really our target. But again, if they're private pay and they meet the other criteria, we still see them. So the only people we absolutely don't ever see are those who are going home or who are on managed care. And that would be like the United Healthcare, Optum, Evercare, things like that. I don't know if you've heard of those different programs, but something like that that's a managed care. Now, we will not see them because that's a duplication of efforts. They actually got awarded the program in 2012, but we didn't actually get in the facilities until 2013. The 2 more years, it'll be up September of 16 is when CMS calls an end to this. I've already said, we have the dedicated RN in each of the facilities, plus we have the nurse practitioner. So the RNs, they're not there to do the work of the other nurses in the nursing home. They're there as an extra person to help assess, to look at changes in residents. We look at them with a different eye. And we can go that step further, and we can help that overburdened nurse. She says, well, yeah, but I don't think anything else is going on. They did this. Let me go look at them and see. I'll go look at them. If need be, I'll call my nurse practitioner. They can actually help with paperwork if they need to. They can do a lot of the same things, but we don't take the place of a facility nurse. It is an additional person. The nurses have advanced care planning discussions. We have found that a lot of times patients are sent out simply because they're a full code. And why are they a full code? Because the family thinks DNR means do nothing. Do not treat this person. Well, if I'm a DNR, then you're not going to give me antibiotics. You're not going to treat me. You're not going to help me if I'm sick. You're just going to let me die. And that is not true. And that's where the post comes in. If those of you who were here yesterday, I don't know if any of you heard of the post that came out, that the legislature came out with. We'll talk a little bit about that at the end of at the end here. And very good piece of paper. And we have gotten really good discussions with families. Well, no, they don't want to be kept alive on machines, but what's my choice? Well, you've got a lot of choices, so we're going to talk about them. Quality improvement. Have a lot of our nurses now looking at falls. We have a point person in the facilities that says, this is our big problem in the facility, can you help us? They do root cause analysis. Why is this happening? I had one facility that was having a lot of falls on the dementia unit, and it was simply because the time of day. It was when staff was changing. Simple fix, change your staffing patterns so there's somebody on the floor all the time. Because we were finding when they were in report and there was really nobody on the floor, that's when the falls were happening. They changed their staffing patterns and it's magically worked. Haven't had that many problems. As a nurse practitioner, I don't take the place of a primary care physician. I work with them. And the good part is that we don't bill. For those of you who have ever had to bill, you don't have to bill. Because since this is a grant, basically CMS is paying my salary. It's not a duplication of services. And the doctor or the primary care nurse practitioner can still come see this resident the same day and bill. So we're not impeding that process at all. We're not taking that place or taking anything from them. And that's been hard for some people to grasp because everybody that walks into a nursing home wants to tell you what you're doing wrong. They do. State has to come in and do their surveys, and rightly so. But what do? They come in with a critical eye to tell you what you're doing wrong. Higher ups in the company come in. What do? Tell you what you're doing wrong. Everybody's telling you what you're doing wrong, and nobody wants to say, hey, you know what? I saw what you did, and that's wonderful. Thank you. We need more of that. And that's another thing we do. It's not in our description, but that's what we do. We go in there and we say, hey, you're great. Keep that up. Or if we see someone doing something that's not the ideal way to do it, we'll say, can I give you a little, can I show you something? I think this might be a little easier, or this might be a little better. So it's just a different approach. The interventions we use are comprehensive care reviews, where we kind of break down the resident, sum them up in one page, look at the geriatric syndromes. Are you on too many meds? And we find we can knock out a lot of meds sometimes. And of course, we don't do it. We make the recommendation, take it to the primary care. After I fill out my CCR, I have to send it to my doctor, staff it with my geriatrician. We talk about it. We come up with recommendations. And then we send them to the primary care and say, these have been our recommendations for this resident. Do you agree with them? If you do, if there are orders to be written, I'll write those orders. And the longer this goes, the better reaction we're getting. Because I think at first they didn't know what to do with us either. They're like, what? No, I'm not telling you you're doing it wrong. I'm just saying that from a geriatric standpoint, this is a little better. The transition back visits. We have a resident that goes out and comes back. I do a visit on them. The ones in my facility, all the NPs do those. We look at the entire visit. Now, those of you who work in long-term care know you don't have the time to sit there and read every piece of paper that comes back from the hospital with these residents. And you may miss something. Not because you meant to, but because it's buried in the middle of 150 pages, and you don't have the time to sit there. So you take the discharge summary, which is supposed to be the summary of the visit, and a lot of times it isn't. So that's a breakdown at the hospital. So then we try to make sure we catch those things. I had a little fella go out to dementia care. He got combative, and it was a resident on resident, so you have to send them out. There's no way around that. And when he came back, he started getting cranky. I mean, real cranky, like we thought he was going to take a swing at the staff. Simple fix. I read through the hospital transition, looked at the discharge paper. Speech therapy at the hospital said he needed mechanical soft diet, right? The discharging physician said he needed a dysphagia diet. The dysphagia diet at the nursing home's puree. We almost had to send him back out because of food. Because he was mad because he wasn't eating that stuff. He wasn't a baby, and he wasn't eating that stuff. Now, had I not been able to be there, and it was and a funny thing, it was another weekend, it was a Saturday. So if I hadn't been there that day looking through his discharge, that would have never been caught. The nursing home didn't do anything wrong. They did what they were supposed to. They took the orders off the discharge. But when we found that, I got to change the orders back, and we got him his lunch that he wanted, and he was a happy camper, and we avoided sending him back out. Cue cards. Started using those. It's just a piece of paper, has predetermined areas, and when somebody's coming back from the hospital, they're supposed to call you, report on this person, or call it to the nursing home. The nurses are using those to write in all their information, and if it doesn't automatically come, they can ask a question to fill out the rest of the card. It should be everything they know to be able to readmit that person. The advanced care planning interventions, like I alluded to before, we've had really good success with talking to people about what their real wants and wishes are. And the post program, that's where we bring post into it, and we use the Gunderson Health Systems Respecting Choices way to do that. It's a way of having a conversation, having that crucial conversation, giving information and getting information. It's not about saying, well, you need to do this or this. It's about what do you want to do. If the resident can talk with us, if they're cognitive enough. If they're not, we talk to that family. Find out from the family, what have they said to you? Did they ever put anything in writing? You'd be amazed what you find out. The Interact 2 tools, have any of you heard of those? They are online for anybody who wants to go pick those up. Joe Auslander started the Interact program, and he has the S-bar. He has different, they're pre-prints. You can print them right out. They're free to use. The only thing he asks is that you don't take the Interact 2 off of it. You have to leave his logo on them. Just some really fantastic tools. Stop and watch. Anybody in the facility can use a stop and watch, from the dietary and laundry all the way to maintenance, and the ED can use a stop and watch. It simply means, I noticed something wrong. They fill out the little stop and watch, they circle what they think it is that they've noticed differently, sign their name, they put the resident name on it, sign their name to it, and they put it in a box. There's duplicate copies. And then the nurse will follow up on that. As where before, somebody may not have said, hey, laundry, and they think, gosh, I wonder why she keep having all this extra laundry from her. This is crazy. And they just go do their laundry instead of going to the nurse and saying, Mrs. Smith, I've picked up 3 wet pairs of trousers out of her laundry basket this week, and she's never had wet pants before. So that tells you that there's probably something going on with Mrs. Smith. Where before, the laundry wouldn't tell you anything, but they can keep these little stop and watches in their pocket and take them right with them. Because we know if they're not eating, who's the first person that sees they're not eating? Dietary. Because if a dietary person's paying attention, when they clean off the tables or clean off the trays, they're going to see whose tray it was, and they're going, wow, they left everything on their plate. This is the 3rd time in this week that the last 3 nights that I've worked, I work second shift, the last 3 nights I've worked, they haven't eaten their dinner. So that dietary person can go to the nurse and say, you know what, she's not eating dinner. And I know from experience you cannot count on what it says in the electronic medical record of what they ate for dinner. They eat 1 to 25%. You know what that means? They might have taken a bite or a half a bite. That's not 25%. It is what it is. So we kind of have to work within these parameters, but we also need to have those critical eyes looking at those minute little things. The SBAR communication tool. That way, you've got to write down this information anyway, ladies. I'm saying ladies because that's the majority of who I work with in the nursing homes are the female nurses. I'm like, you got to call the doctor. You got to have this information. You're writing it on the palm of your hand. You're writing it on a napkin, a paper towel, or something. Have a stack of these on your med cart. You fill it out right then and there. When you go call the doctor, you've got all the information he's going to ask you, and you can get help for this resident sooner. And then, of course, clinical care pathways. We have certain pathways that we have instituted in these buildings, and hopefully they're using them. I know some facilities are. I think some of them are still having a little pushback on them, but we're still working there. The evidence for avoidable hospitalizations. 45% among dual-eligible patients, 45% of all hospitalizations were avoidable for some reason. It was $2.6 billion in 2005 on this, so it went up to 7 in 2011. Evercare, which is now Optum, which is United Healthcare's managed care, says they reduced their hospitalizations by 47% and emergency department use by 49% because they had an extra person in the facility. New York, the facility employed staff provider. In other words, I'm hiring you to be here just for my people. 16.3% reduction. And then, of course, the Interact 2 reduced the hospitalizations by 17%. That's because they have all the information they need. They don't have to keep running back to grab a chart. You don't get an irritated doctor because it's 2 o'clock in the morning and you don't have all your information. This is a little schematic of how this works. We look at risk factors, symptoms, any change in condition, because any small change can be a big thing. I use my father a lot. My father passed away in 2010, and I took care of him at home until he passed. But I knew he was declining because one day I get up out of bed and I noticed he hasn't made his bed, because he always made his bed every morning. He had his own routine, and making his bed was part of it. So I waited, and I kind of hem-hawed around because my dad wasn't very forthcoming with information. And finally, about 2 o'clock in the afternoon, after he'd eaten lunch, I said, Dad, something happened to your sheets? He had a catheter. I said, did your catheter bag leak? He goes, no. I said, okay. Well, I noticed you didn't make your bed today. Is there something I need to know? He goes, no, I just didn't feel like I could do it. Okay. He never made his bed again from that day forward. That was that very small change that I knew we were going down that path. The next thing he quit doing was going out to get the paper. Okay, so he's 87 years old. He's not going out to the mailbox every day. No, for my dad, that was a big deal. Then he quit going out to the barn to feed the cat. Ask us to do it. So those small, that's what we call that slow functional decline. He didn't have it in him, so we see that in our residents, but we have to be looking for it. What were they doing last week they're not doing this week? We look at transfers, we track those transfers, we do quality improvements. That's where we find out, could this have been avoided, yes or no? The transfer backs, we do the cue cards when they come back. Hopefully we get really good information, and then we do the visit. And then we go right back again, and we keep watching this resident so that we don't hopefully bounce them back. These are some of our statistics. There were 1,137 unplanned acute transfers. In other words, something happened and we needed to send them out right now. And we had 513 advanced care planning discussions. And this is kind of how it teased out what we found out, that the biggest risk factor for going to the hospital is any hospitalization in the last 6 months. If they've been there, chances are you have 44% chance they're going to go back. For some reason, like my little guy with the food issue, he would have gone right back for another resident, or resident on resident, or a resident to staff. He would have gone right back out for hitting somebody because he was getting angry. Dementia and behaviors, there he is. So he has 2 of those risk factors. He's got dementia with behaviors, and he's got hospitalization in the last 6 months. Hospitalization in the last 30 days, you still have a high risk of going back again. A lot of times they just don't get them as stabilized as they should before they pop them. Thank DRGs for that, but like to change those, but they're not letting us look at those right now. COPD is another big one. People get scared. You can't breathe, it scares you. I wouldn't want to smother either. It's being able to notice that they're getting into trouble before they really get all the way there, trying to stop it, and then trying to make sure they've got the right meds to manage them. So again, just another way to look at the different percentages of what we found. And see, right here's another one. It's not real high on the list, but it still causes problems. Your dose change or your new medication. They've had a bad reaction to it, so we send them out to the hospital. Because we don't look at it's a medication problem. Maybe it's not that med, maybe it's just the interaction with another med. So, transfers, 49% of the time were initiated by a doctor, the PA or the NP. Facility staff, 27% of the time. Now, what I don't have is, when they look at these percentages, I actually have the data on whether or not it was necessary, but not teased out as to the percentage of necessary ones by the doctors or by the facility. And this is what's scary. Medical evaluation prior to transfer, telephone only. Look at that. 68%, telephone only. That means you called somebody that 9 times out of 10 did not know that patient. And what happens is that we live in a society that everybody wants to sue somebody. So we've gotten used to, well, I don't know, so you better send them out. Which is sad. because we know people with dementia, they change their environment, they get more confused. And we're chasing our tail again, trying to get them back to their square. 6% of the time it was an MD visit. So I would say they probably needed to go out. If the doctor said send them out, they probably needed to go. Optimistic NP visit, if we tell you to send them out, I'll tell you what, they need to go. Because we're not going to send them out if they don't need to go. The other 7%, I think that was the ones where they really weren't sure. It wasn't a clear-cut reason who sent them out or who initiated it. Not a lot of difference between the day of the week. You see it spikes just a tick on Fridays, and I think that's because they know the on-call people aren't going to know these people, so we better get this taken care of right now because I don't want something bad to happen. Time of day, first shift, second shift, you didn't see much difference. Night shift went way down. Well, that's probably because at night you're hoping that they're resting. They're not up running the hallways, falling, getting aggravated, smacking other people. And it happens. It happens. Trust me, it happens. We look at the tools, so we know if our tool is working. So the acute care transfer form, 63% had one. We need to work a little more on our stop and watch. Only 3% of the people that got sent out had a stop and watch. But even with 3%, that tells you those 3% might not have been caught had they not had a stop and watch. The S-bar, 25% used that. So that tells me they had all their information. The doctor said, hey, we need to send them because they had everything they needed to talk about. The difference between that 25 and the 63, that's kind of up for grabs as to whether those really needed to go. And on those transfers, that 1,137 transfers, it was determined through analysis of everything, 34% of them were probably not necessary. Or avoidable, okay? 21% says definitely not avoidable. Something happened. They fell, they injured themselves, we had to send them out. But definitely avoidable, 5%. And that's too many. And that's just in 19 facilities. Okay, that's just 19 facilities. That's still too many people. And then the probably, we need to work on that one, that's 18%. So we still have work to do. The second quarter information just came out. I didn't have time to get it on the slides, but we're going in the right direction. Everything's pretty much like trended down a few percentage points. So like with anything else, it's going to take a minute, but we're going the right way. And that's good that we are going the right way. Again, the quality improvement, we're looking at what could we do better? How can we get these numbers better so that someday it definitely wasn't avoidable will be the highest mark instead of the probably, So condition managed better in the facility with available resources, 23%. In other words, you had what you needed, you just didn't use it. Or maybe you didn't know you had it. You didn't think to use it, so we need to do more education. Changes in the resident communicated better. So that means the handoffs, the charge nurses handing off on the shifts, they need to do a better job of talking to each other. Facility did not have the resources to manage the conditions safely. Sometimes we just don't have what we need. And that will probably not change. But we're hoping that by earlier intervention, seeing those things earlier, then that will change. New sign or symptom detected earlier, 19%. We need to pay more attention. The advanced directives and or palliative or hospice care are put in place earlier, 13% of the time. People are so afraid. And we're really working hard so they're not afraid. I tell all my residents and their families, I'm never going to tell you there's nothing I can do. I may not be able to heal you, but I can always do my best to make you comfortable. So there's always something that we can do. Resident and family preferences. So we need to talk to them. What's this preference? And make sure you're talking to the right family member. Because you want to talk, if they have a POA, you want to talk to that POA, not the third sister down on the line that lives in California. Because the third sister on the line in California is so riddled with guilt, she has no clue what's going on, so she thinks you better do everything anyway, and even though that's contradictory to what everybody else wants. Make sure that's one thing, you've got to talk to the right person. And if your resident's cognitive, who do you talk to? The resident. And I see so many people, well, they have a POA. I don't care. They can talk to you. They know what they're doing. Talk to them. I can do that? Yeah, I think so. Last time I checked, yeah. So we're back to our little old lady that has the COPD and the history of the UTI and the sepsis and all this. And she's had this big change in condition, which the RN noticed. And came to me with, hey, I don't know what to do here. This is, she's had this, boom, what are we going to do? So, he did what he was supposed to. He informed the optimistic NP, which happened to be me. I was in the facility. He did an SBAR, gave me the information, opened up the EMR and started his event, which means at that particular facility they use Matrix, and the EMR is Matrix, and in that one, if you open up an event, it's called hot charting, and it puts a little notation, a little red notation that means you have to chart on that person every shift. You have to do an assessment, so it automatically pops up for you. So I ordered a stat chest x-ray, a UACNS, some labs, and now you know your stats are 4 hours turnaround in a nursing home, right? And then a CNS, that's, even though it's stat, that still takes a while. So, got her on some neb treatments, make sure the O2 was on. So now, does anybody want to give me a guess of what they think happened or should happen, or if they would have done something differently?
Maybe a CBC for sepsis.
Okay. Well, see, on a weekend, what would have probably happened, if I wouldn't have been in the building, they'd have called the on-call person who doesn't know this person. Send them out. I don't know. They don't sound good. Send them out. Okay? When we finally got this back, the chest x-ray was negative, but the UA came back, just full of crap, just all kinds of crap. I put her on a broad-spectrum antibiotic even before the culture came back because I wanted to try to stave off. Now, in this case, what she had, we had to change the antibiotic because it was resistant to what I'd started. But again, because there was an extra set of eyes, we were able to keep her in the facility, not get her sent out. We got to have that talk with the family, because even though she was a DNR, she didn't have a post form. So we weren't real sure if this went the bad way, what could we do? The advanced care planning discussions, I said something about post earlier. How many of you know about post? Okay, for those of you who don't, post was made legal in Indiana in July of 2013, and it is physician's orders for scope of treatment. Now, there are some caveats. Almost every nursing home resident qualifies for one. I would say anybody in this room does not. We're too healthy. You have to be really sick, pretty much. You have to be, the doctor would not be surprised if you died within a year. Doesn't mean you're going to die. It just means he wouldn't be surprised if you did. Long-term care residents pretty much all fall in this category. So we managed to have 513 discussions so far because, it's hard to get with families. They have work schedules, they have kids, they have all kinds of things going on in their lives. So we try our best for the ones that want to. The caveat with post is that if I ask you if you want to talk to me about a post for your relative, and you tell me no, you're happy with the way the orders are now, I cannot ask you again unless there's a major change in condition with your loved one. Now, you can come to me at any time and say, you know what, I want to talk to you about that. But the state did that because they didn't want people being badgered. They didn't want people to feel as if they had to fill one of these out. Now, the plus side is that you fill it out. Section A says, CPR, no CPR. Do you want me pumping on your chest or not? Yes or no? Real simple. That's all that's in that section. Section B goes into what additional treatments do you want? Do you want full court press? Do you want the ventilator? Do you want ICU? Do you want all that? Then there's limited interventions, which is everything up to going on a ventilator. So you can do BiPAP, CPAP, things like that, non-invasive. And then again, there's the comfort, where we're going to keep you here as long as we can. The only time we'll transfer you is if we cannot manage your symptoms here. And then of course, like I said, section C is antibiotics, and section D is feeding tubes. So it actually completely teases out all of these decisions that people have been putting in living wills, and that was simply a suggestion list. Because we all know that families come in and they will hide the living will if they don't like it, or they will, they can actually go against the living will if they want to, because it's not an order. This is an actual order, because after you fill it out, it gets signed, the physician signs it. It is a legal document, and it can go anywhere with these people. So if your patient who has a post with no CPR, comfort measures only, no feeding tube, antibiotics for goal of treatment, they fall and break their hip, you send them to the hospital, they still remain no CPR, no feeding tube. It's not like you send this other guy out with an out-of-hospital DNR who goes back to the hospital and all of a sudden comes back with a feeding tube and a trach and everything else, when that's not what he wanted. Because you send him to the hospital, they automatically become a full cook, unless there's somebody there to tell you different. And when we send our residents out, a lot of times there's nobody there. They'll meet them there later, but if you send them out emergency, like with a broken hip or a broken bone, you don't always have that luxury to have someone to go with them. The Respecting Choices model is being used. All 19 of the RNs have been trained as trainers, and there were 7 of us that were trained as instructors, so that we can go forward and actually teach other people how to use the Respecting Choices model of having those conversations. And when we talk about it, we break the post form down and we say, hey, this section is about tube feedings. And what do you know about them? We try to find out what that resident or that family knows about these things. What do you know? What questions do you have? And then we have a paper we can hand out to them that will give them some more information. It's written in lay terms, so it's not like they're still left guessing. And then they can make an informed decision as to what choices they want to make. And it's definitely not a leading conversation. You don't try to lead them in a direction. You give them facts, and then they get to decide for themselves. And I found that people really like that, especially the ones who don't want the CPR, but want to make sure that they're going to get treated for pain and infection and things like that. Again, the transfers, there's a multitude of reasons why we have to transfer residents out. And again, most of them was that telephone initiation. So, we really have to work with the docs. And then again, with the facility to say, hey, use that S-bar. Get your information so that the docs will know what's really going on. Give them a good picture of what this resident's looking like. What's changed? Not enough using the S-bar or the Interact. We need to do those a lot more. Opportunities for improvement were identified in 63% of the cases. So what we've done is we've taken all this information and we will go back to that facility and say, hey, this is where we need to improve things here. We never compare facility to facility. So facility A does not know what facility B looks like. Facility A knows what they look like. And facility B knows what they look like. Where they fall in the spectrum of preventable, non-preventable, things like that. But we never compare facility to facility. So it's not like it's a game. We're not going to give anybody information. We'll give you your information, but we're not going to, it's almost like HIPAA. HIPAA for facilities. But again, we have been able to change some of these full codes. Like on the long-term care unit, we had one facility where 93% of the people with dementia were still full codes. So we had discussions with the families, and when you have someone with end-stage dementia, they're losing weight, they're not eating, because that's part of the disease. We know that no matter what you do, it's not going to work. So it's a lot of teaching, especially families, about disease processes and letting them wrap their heads around it. It's not just the old senile dementia, I'm confused and, I may think you're my sister, instead of my daughter. So we really try to get that extra teaching in there and help them. And along the way, we've had some really fun things happen, and you find humor where you can get it. Healthcare professionals, we're all a little on the dark side. Well, we try not to let it show, but it just sneaks out. I had a little man that, God, we loved him. He was one of our favorites at one of my facilities, and his name was Edison. And Edison was 98 years old. He recently passed away. And Edison, my last memory of Edison, I was walking down the hallway with one of the nurses who was leaving, and he calls out to her. He was in his room. He said, hey. She said, what you need, Edison? He said, you going to the store? She said, well, I could. Do you need something? He said, yeah. She said, what do you want? He goes, I want a box of My Doll. She stood there like this and went, what? He said, My Doll. I want a box of My Doll. Can you get that for me? And she said, no, I can't get you medication. She goes to me, I'm not touching that. I do not even want to know why he wants a box of My Doll. So for him, he was just this goofy little guy that he was confused, but he would pop out with some of the strangest requests, like for a 98-year-old man wanting a box of My Doll. I'm like, okay. So we do have some fun things. You've got to find the crazy humor, where you can get it. And sometimes, if we didn't know Edison, we would have picked that up as a red flag, something was going on. For him at the time, it wasn't. But we knew when he did get confused, it got really crazy. And we always knew what the reason was. Every time. And this last time, he just couldn't fight it. But he's left us all with a lot of good memories. And that's the wonderful thing about long-term care, is that you always have these people that just touch your heart, and you remember them for the rest of your life. And we're trying to help them to have the best quality they can have while they're with us. Now, hopefully, CMS next month will say, hey, guess what? We like your model, and we think it's done the best. And if that's true, this will be something CMS is going to roll out nationwide. So we might be coming to a nursing home near you. You never know. Hey, that's
So
right.
at the end of this project,
Yes,
CMS is paying you now.
yes,
So at the end of this project, they come to the logical conclusion, which we could have told them in the first place,
right,
that it would help to have an extra pair of eyes.
right.
Then what?
Well, if what's going to happen is next month we find out, we may not even have to worry about the next 2 years. We may start it earlier, rolling it out into other facilities with the same setup.
But are they going to continue from now on to pay people?
I don't know how that's going to look. CMS hasn't decided that. They said, I know that the facilities, one of mine in particular, said they do not want to be responsible for it. They want it to be a third-party rollout so that it'll keep them honest. So that they won't say, well, you're under this money today, but I'm going to pull you to do this. And if you're not working for the facility, you're going to have honest numbers. You can't jockey the numbers around. So hopefully CMS will decide to keep it like it is with a third-party, person, like we're third-party with IU in the facilities. And I know that if they do choose us, that what we're going to do, the people in the grant, we are going to actually move into the role of trainers for all the people that'll be hired to do this job. So we'll be going out training people in the optimistic way of doing this, looking at these transfers and things.
So who will be all the third parties for this?
I don't know. We'll find out. We don't know. CMS only gives us this much information at a time.
Because that's all they have.
Yeah, well, or they like to have big bang. Hello. But no, they did say, and Evan, who is our CMS contact for this project, when he was in town in March, he said there will be a decision made. It will be made before the 4 years is up, and he said this will be done. So we know it will happen. Which model they're going to choose to roll out, we don't know. But I do know that this model that IU put together is one of the more intensive models, especially with all the data collection. Because we even work with the Healthy Aging Brain Center, Dr. Gregory Sachs, who is over that, with Dr. Bustani, with the Indiana Discovery Network for Dementia. So we've got a lot of really good people on board with this project. And it's, like I said, it's just going to be a matter of if CMS rolls out our project. It will be a little different because the providers are going to be working with another provider, an NP, who doesn't work for them. And getting them to understand, I'm not here to hurt you, I'm here to help you. That's been one of our biggest challenges, is trying to get them to understand, I just want to help. I have 5 buildings, and out of the 5 buildings, I have 1 building that has embraced us, enveloped us, and they look at me like I belong there. I walk in the door and they're like, oh my God, we're glad to see you, come here. And you would think I was the primary care provider. They have embraced Optimistic that well. And the other ones are like, hi, and walk on. They're not rude, they just don't engage because they don't think they have to. They think, at this point, they think it's an option. And we've tried to tell them this may not be an option, so the sooner you get on board, the easier it's going to be for everybody. So we've had some pushback, and we've learned lessons on if this does roll out nationwide, what do we need to do? What are the lessons we've learned that we need to take forward? And another thing is that we have embraced families because the families know we have the extra time. And the families who are, very engaged with their loved ones. And I have facilities that they have people that don't have families that are engaged, and some just don't even have families. But in those facilities where you have that engagement, the families have embraced us. And they will go to the RN a lot of times before they'll go to the staff nurse. Not because they don't trust that staff nurse, but because they know that staff nurse is busy. And they know that our RN has a little extra time, and she can devote strictly to that one person and not be interrupted with someone else needing medications or a CNA needing help or something else. And again, it's a collaborative effort because whatever goes to me, I take to the primary care. Whatever goes to our RN, she goes to the facility. I talk to the facility ED. If he needs to know something, I always make sure that the unit manager knows if I've made a change on something. If I've written orders, I go straight to the nurse that's going to be taking those off and explain those orders, talk to them, let them know what I saw, why I saw it. I have that luxury. I can do that. And I know they have really appreciated that, because some of them said, I learned so much that way instead of just looking at an order and not knowing why it's here. I explain myself. And like I said, I'm lucky I have that luxury. So it's been a win-win for everyone. We come in, we do extra teaching. The RNs go around with an in-service sheet, and they'll do one-on-one in-services on certain topics with the staff. One of my nurses and I held a dementia program one night at one of the facilities for families or anyone who wanted to come. We talked about dementia, the different kinds of dementia, and about the post. And we had a real good turnout, and the families really welcomed it, and they liked to be able to talk and to hear what they're going to face. And the staff, it isn't that the staff in the facility didn't want to do that, they just don't have the time. So we've found that this really is a good thing to have these extra people on board. So hopefully Indiana will hit the national market. We'll say, hey, look, it started right here in Indiana. So it's very exciting, cutting edge stuff. And we're learning a lot from our stories. We know that CMS is looking at hard data. They're looking at that qualitative stuff. But CMS has also learned in the process that sometimes you can't put it in a category because it is quantitative. It's a story. It's how did I help? And it doesn't fit into a category. How did you impact this person's life? It's by spending 4 hours in the afternoon with the family of a 63-year-old ALS patient who's dying. Not that the staff didn't want to sit there or talk to them. They just didn't have the opportunity. But we know that family, we made a difference for that man because he was comfortable. We made sure of it. The family was at peace with the decision, which they weren't to begin with. So it's just little things like that do a lot of things. And the other thing is always saying thank you. I'm always telling the CNAs thank you. Thank you for taking care of these people. I know it's been difficult. I know you've had a hard day. And I know you have a hard job. And they do. And they look at me like, you're kidding me, really? You told me thank you? I did. And I told the CNA one day to do something which was opposite of what she was supposed to do. And I said, and don't you worry about it, because I'll tell the nurse that I'm the one that told you to do it. It was about a patient that I wanted in bed, and it was time to get them up. And I said, no, they need to be back in bed because of their condition. So I went to the nurse and I said, now listen, I don't want you getting mad at this aide, because she was getting ready to she did have her up already. And I said, I told her to put her back in bed. I said, so she did not, it isn't that she ignored your directions. It's that I told her something different, and I want you to know that. And then I went back to the aide and I said, I already talked to the nurse, so you shouldn't have any problems. I just wanted you to know it's taken care of. And she appreciated that. That way she knows somebody's actually trying to have her back instead of constantly telling her what she's doing wrong. Do you have any other questions? Yes?
Explain a little more about, you mentioned a cue card.
Cue cards, yes. It's a sheet that is like a report sheet for one patient. And they will use that cue card when they're getting a transfer back from the hospital. They can write their name on it, what their diagnosis was, if they have any changes, if they have any tubes. The nurse at the facility. Yes, the one taking the call, the transfer back call.
Okay.
They will use that cue card. Dr. Mike Lamontia, who worked with us for a while, he was an inpatient geriatrician, and he's the one that initiated that because he was used to having something similar to that when you would get patients from another floor or another unit, and you'd ask all these questions, who am I getting, what am I getting? And it's worked really well in the facilities that are using it. And they're putting them in the chart so that you can see, and then to see if it's nice to see when it jives with what actually comes back from the hospital. Yes.
Available online.
The cue card is not. No, because that was something that IU developed themselves for the project. That one is not. However, if you go to the Interact 2 website, there are, it's interact2, the number 2.net. They have all kinds of forms, and they have something similar to the cue card. I think it's a transfer back form or something, and that's, I think they just kind of condensed it and made it their own. So like I said, that cue card isn't there, but Interact does have those tools. And the only caveat, like I said, is that you have to leave the Interact logo on the forms when you print them. That's the only, but they have a lot of good information on that website also. Okay. Thank you very much. And I hope